Good afternoon, everybody. We are delighted to host you today in this webinar that will discuss the specific role of non-invasive ventilation with focus on high-flow nasal cannula. We have a group of fantastic speakers today, and with no further ado, let me ask my co-host, Dr. Fratt, if you can first introduce the speaker.
Thank you very much, Sharon. It's my pleasure to present Bram Rosberg, working in Hamilton, Canada, Department of Medicine and Clinical Epidemiology and Biostatistics at McMaster University. And he's an expert on meta-analysis. He published many meta-analyses and also many guidelines on the use of NIV, and recently on the use of high-flow nasal oxygen therapy. Thank you, Bram, to start this session, and you have 50 minutes.
Thank you, JP and Sharon, for the kind introduction, and it's absolutely my pleasure to be presenting today on high-flow nasal cannula and acute respiratory failure, specifically discussing what the guidelines say. In terms of declarations, I should mention I treat patients with acute hypoxemic respiratory failure. I am an adult intensivist. I do work as a methodologist for a number of national and international organizations and was the methodologist for the European Society High Flow Guideline, which we'll talk more about. I have no other academic or financial conflicts of interest to report. This is the guideline that came out just in the last few months. We addressed 4 PICO questions as part of this, 4 clinical questions. The use of high flow in the setting of hypoxemia, post-extubation, peri-intubation, and in the post-operative setting. And it is for these 4 indications that we'll discuss some of the evidence and recommendations a little bit more. We were fortunate enough to actually publish each of these meta-analysis as standalone publications in ICM, CCM, or CHEST, which was an added benefit here, and provide more details around some of the evidence summaries. Before I get into some of the details, I thought just for a moment it might be interesting to discuss how the generation of guidelines and producing trustworthy guidelines has evolved over the last 10 or 15 years. And really with the publication of this guideline, We Can Trust from the Institute of Medicine, a lot of these main tenets came to light. Conflict of interest management is crucial, both academic and financial, and this guideline was no different. We had very strict rules in terms of reporting and who could be involved in which questions. Having a representative panel, including multidisciplinary stakeholders, is crucial to make sure that all viewpoints are heard. Coming up with questions, prioritizing outcomes ahead of time, also crucial. As you've seen, each of the questions is addressed with a standalone systematic review meta-analysis. We rate the certainty of evidence for each of these outcomes and questions. In addition to considering the evidence, we also consider the balance between benefits and harms, the quality of the evidence, individual patient values and preferences, costs, resources. These are all combined and considered when coming up with the recommendations themselves, and they lead to clear, actionable guidance for clinicians. That's ultimately the most important, and to do this all using a very transparent process. We're left with either a strong or weak or conditional recommendation. Strong recommendations identify the fact that most well-informed patients would choose this course of action, as opposed to conditional or weak, and those are synonymous. A conditional and weak recommendation are equivalent. And here recognizes that the majority of patients, well-informed patients, would choose the recommended course of action, but there might be a minority of, or at least a large minority of patients that would choose otherwise. And here it's where the benefit and harms more closely balance each other. All right, let's get into the meat of the recommendations. And let's start with acute hypoxemic respiratory failure. This is the summarized evidence across all randomized controlled trials looking at the role of high flow in hypoxemic respiratory failure. And you can see, for example, for mortality, 4 randomized controlled trials, including 1,400 patients, address this outcome. And looking at the pooled risk ratio, 0.94, fairly difficult to make any assessment in terms of conclusions for mortality with wide confidence intervals that go from 0.67 to 1.31. So a fairly uncertain effect on mortality, but our best guess is no real difference. However, when we look at intubation, you can see reported across 7 RCTs, 1,600 patients, and a statistically significant reduction in intubation in those that used or were randomized to high flow as compared to standard of care. This based on low certainty evidence. You can see the upper end of the confidence interval approaches 1 or no effect. But certainly our best guess is that the use of high flow in patients with de novo hypoxemic respiratory failure reduces intubation. Certainly consistent with what I see at the bedside as well. I think with the increasing use in high flow in the last 5 or 10 years, it feels like we're probably intubating less. Patient-reported dyspnea reported in 5 RCTs may be lower in those that are randomized to high flow, although you can see wide confidence intervals. And there's pathophysiologic rationale why patients with high flow might feel less short of breath, and in so much that we're able to more closely match their inspiratory demands, that when patients come in with dyspnea, they're sucking back and hoping for flows in the range of sometimes up to 80 to 100 liters per minute. And standard oxygen therapy often not able to match those inspiratory demands, whereas high flow that can achieve flows in the range of 60 to 70 liters per minute, probably more able to match those inspiratory demands and therefore help alleviate that feeling of dyspnea. We looked at complications, and they were very heterogeneously reported and difficult to summarize quantitatively, but no difference between groups. Some have suggested that there could be harm in using high flow, especially early on in these patients, in so much that we might be delaying intubation, and those that inevitably end up still requiring intubation, and might this delay be associated with worse outcomes? And this group from South Korea examined this exact question using a retrospective observational design, 175 patients, and they looked at patients that ultimately ended up failing high flow, requiring intubation, and compared those that failed early versus those that failed late, wondering if perhaps in this subset that are destined to fail high flow, could the delay enacted with high flow lead to harm? And they did see an increase in ICU mortality and a decrease in ventilator-free days in those in the delayed arms, suggesting that there could be some harm, especially in those that inevitably end up requiring invasive mechanical ventilation in delaying things. However, obviously, given the design, there's confounding at play here, and this requires further evaluation and larger prospective studies. Despite this, the guideline panel, when weighing those benefits, a decrease in intubation, compared to the harms, felt like the benefits far outweighed any potential harms, and made a strong recommendation for using high-flow nasal cannula in patients with hypoxemic respiratory failure. It was felt that high flow is relatively safe. The largest complication described is usually nosebleeds from interruption of the nasal mucosa with the high flows, but this is often compensated by using a humidified circuit. We did find one cost-effectiveness study that suggested actually cost savings with high flow despite the resource costs with purchasing the units. This decrease in intubation and decrease with days requiring ventilatory support and ICU support translated into net savings. A lot has been made of the role of high flow in patients with COVID, and I think you're going to hear about this more soon in one of the subsequent lectures. There's concerns about risk of aerosolization. However, I was involved with this review published in the Canadian Journal of Anesthesia, found 7 eligible studies looking at healthy adults, simulators, and those with gram-negative pneumonia, and at least from this review found no increased risk of aerosolization or risk to healthcare workers when using high flow in patients with COVID. Moving on from hypoxemic respiratory failure, what about using high flow in the postoperative setting? We found 6 or 7 randomized control trials that specifically looked at this. All studies used high flow in the setting of prophylaxis for postoperative respiratory failure rather than treatment. And all studies specifically looked at high-risk surgeries like cardiac or thoracic surgeries. And they dichotomized patients into those that were high risk, those that were obese, had a high ARISCAT score or had underlying lung disease, as opposed to patients that were at average risk. And this is the need, this forest plot summarizes the need for reintubation postoperatively. And you can see that there appears to be benefit in those that were high risk, which is not seen in average risk patients. I do want to alert you to the fact that the numbers in terms of reintubation are rare. So although it seems like there's benefit, the number of events are quite small. And weighing these pros and cons, the guideline panel ultimately decided to make a conditional or weak recommendation for using high-flow nasal cannula post-op cardiac thoracic surgery, specifically in patients that were high risk or obese, for a lot of the reasons that I've already mentioned. One of the other benefits of using high flow in this population for prophylaxis as opposed to non-invasive positive pressure ventilation is that it doesn't necessarily always mandate a post-op ICU admission. And some of these patients may be able to be managed on a step-down floor or on the ward, thereby preserving resources as well. The third question looked at the role of high flow in the peri-intubation timing, specifically looking at high flow for pre-oxygenation before intubation, but also the benefits of high flow is that they can stay on even during intubation itself, often not getting in the way of direct or video laryngoscopy. We found 10 RCTs that looked at high flow specifically in the setting, 2,200 patients. 5 of these RCTs were in perioperative patients undergoing intubation, all high-risk surgical settings. And 5 of these RCTs were in critically ill hypoxemic patients looking at the peri-intubation timing. All of the interventions amongst these studies looked at, as I said, high flow both for pre-oxygenation, 3 to 7 minutes prior to intubation, and also left on during intubation. In terms of comparison, 7 of the randomized control trials compared high flow to face mask or bag mask, whereas 3 of the RCTs compared high flow to non-invasive ventilation. And when we look at the incidence of peri-intubation hypoxia, which is highlighted in this forest plot, no matter whether we look at ICU patients or perioperative patients, it does not seem like the use of high flow here decreases the risk for peri-intubation hypoxia. And therefore, the guideline panel actually made no recommendation for the setting of using high flow peri-intubation. Some in the panel felt like we should still make a conditional recommendation for using, and the panel was relatively split. But ultimately, with no evidence of benefit, we ended with no recommendation, i.e. allowing clinicians to work as they want to. Although we did recognize that perhaps for those that are already on high flow, which we've already committed the resources and the costs, it certainly would be reasonable to leave the high flow on their face during the time of intubation. We'll move on to the last question that was addressed by this guideline, the role of high flow in the post-extubation setting. We found 8 randomized control trials summarizing 1,600 patients that looked at high flow post-extubation. I should mention that all of these looked at high flow for prophylaxis for post-extubation respiratory failure, similar to the postoperative setting, and none of them looked at the treatment of established post-extubation respiratory failure. And amongst these 8 RCTs, they were relatively dichotomized. 3 of them looked at high-risk patients, in which had one of these features that are listed, and all 3 of these high-risk studies compared versus NIV. There were also 5 RCTs that looked at low or unspecified risk patients in the post-extubation timing, and these 5 RCTs in low-risk patients compared high flow to conventional oxygen therapy. And dichotomizing these results based on those that were compared to standard O2 and low risk, as opposed to those that were high risk and compared to NIV, you can see benefit in high flow compared to standard oxygen therapy across the low risk population, and no difference between high flow and NIV in the post-extubation period in those that were high risk. There were no differences in the other outcomes for either the high risk or the low risk population. However, probably not surprised to hear that high flow is generally better tolerated and more comfortable than non-invasive ventilation based on moderate certainty. And so the guideline panel, in looking at this data, suggested using high flow compared to standard oxygen therapy following extubation for patients who are intubated more than 24 hours and have any single high-risk feature. At the same time, they said for patients who clinicians would normally extubate to non-invasive positive pressure ventilation, we suggested continuing non-invasive positive pressure ventilation as opposed to high flow. And these were both conditional recommendations. Why did we say only those intubated more than 24 hours or with any single high-risk feature if the benefit was seen in all low-risk patients? Well, it comes down to the absolute risk and the costs and resources that are included. For patients that are only very briefly intubated, less than 24 hours and without any high-risk features, even a relative reduction in reintubation of 0.46 translates to a very small absolute reduction in reintubation with high flow. And when you're talking about such a low absolute reduction, it makes you wonder whether the costs and resources associated with this are worthwhile. However, when you start looking at patients that were intubated longer than 24 hours and the risk of reintubation starts to increase, especially with risk features, that same relative reduction in reintubation with high flow translates into a larger absolute reduction, and therefore probably more justifiable to entail the resources and costs associated with using high flow in this setting. There's likely no doubt that there is a role for high flow and probably underused in this setting around extubation. I appreciate your time and attention, and I will step away, I think, for the next speaker now. Thank you very much.
Thank you, Bram, for this great presentation. I think we will have, there is a question, but we will ask you this question at the end of the session. So now, Sharon.
So I will continue with the introduction of the second speaker. We are honored to have here Professor Sheila Miyatra. Professor Miyatra is a professor of intensive care at the Tata Memorial Hospital in Mumbai in India. She's president of the AIDAA, which is the All India Difficult Airway Association. She chairs the intensive care committee of the WFSA, and she recently led a global Delphi on the management of COVID-19 related acute respiratory failure in critical care, which was published, in critical care. We're delighted to have you here, Sheila, and the stage is yours.
Thank you very much, Sharon, for that kind invitation. Greetings from India. At the outset, I'd like to thank the European Society of Intensive Care Medicine for having me here. And I will be speaking about high-flow nasal cannula oxygen, strategies for use in patients, and I will restrict my presentation to severe COVID-19 patients. And Professor Rochberg has already set the stage by talking about the perioperative indications of using high-flow nasal cannula oxygen. I'd like to declare that I have no conflict of interest, academic or financial, related to this presentation. Now, when we have patients who come to the intensive care unit with acute hypoxic respiratory failure, we either give them oxygen, conventional oxygen therapy, or we use non-invasive ventilation or high-flow nasal cannula oxygen, or sometimes even a helmet, depending upon the availability. So recently in the intensive care unit, along with intensive care medicine, along with Audrey de Jong and Jonathan Casey, we wrote this article on focus on non-invasive respiratory support before and after mechanical ventilation. And Professor Rochberg has very beautifully given you all the evidence for the perioperative use. And this is summarized very nicely in this cartoon. The indications for initial oxygen strategies during tracheal intubation and after extubation. As he's already outlined, high-flow nasal cannula oxygen is superior to conventional oxygen therapy in patients with acute hypoxic respiratory failure. Well, between NIV and HFNO, there is, the trial from Professor Fratt has shown no difference. However, in the subgroup of patients using high-flow nasal cannula oxygen, there were increased 90-day benefit in 90-day mortality. So that's why we are considering high-flow nasal cannula oxygen more and more in these patients who present with acute hypoxic respiratory failure. As far as during tracheal intubation, in patients with moderate to severe hypoxemia, especially in patients with P2F ratio less than 200, there is a benefit of using non-invasive ventilation. And Professor Rochberg has already talked about the benefits of apneic oxygenation that you can achieve using high-flow nasal cannula oxygen, because you can not only use it for pre-oxygenation during tracheal intubation, but also continue it during attempts at intubation. And we've already got the study in NEJM from Jonathan Casey showing the benefits of gentle mask ventilation during this procedure. Coming to after extubation, there is a role, as Professor Rochberg has already mentioned, for high-flow nasal cannula oxygen and NIV, but only in high-risk patients. So we already know about the benefits of high-flow nasal cannula oxygen in patients who present with acute hypoxemic respiratory failure in the ICU. And we're using a lot routinely to prevent intubations, prevent patients going on mechanical ventilation. So what is different in COVID-19 patients? They present to ICU with acute hypoxemic respiratory failure, and they will need intubation. So high flow can actually prevent many of these patients from getting intubated and should be extensively used. So why do we have these reservations? So if you look at high flow nasal cannula oxygen in COVID patients, when you start this therapy of HFNO, you're usually looking at patient benefit. But with the SARS-CoV-2 virus, we're also concerned about risk of infection to the healthcare provider. So this has really have concerns not only about the patient benefit, but we're also trying to balance this against the healthcare workers' safety. So this has led to concerns because high-flow nasal cannula oxygen, this high-flow heated humidified oxygen that's going to the patient, is considered as an aerosol-generating procedure. So are we exposing our healthcare workers to get infected with SARS-CoV-2 while using this therapy? Should we be using this therapy at all? Was really the question in the beginning of the pandemic. So this is a study that was published in the European Journal of Respiratory Care journal in 2019, and they did a very elegant study. And this was, of course, not in COVID patients. It's a simulation-based study, and they used smoke, and they looked at exhaled air dispersion during high-flow nasal cannula therapy, and they compared this with CPAP using different types of nasal prongs, and they looked at simulated different types of lung injury, both normal lungs, mild, and different severity, and they use high flow at different flows. So HFNO at 10 liters, at 30 liters, and 60 liters. Very interesting study, simulated study. And what did they find? They found that when you use high flow at rates like 60 flow rate, both in normal and mild disease, compared to at flows of 30 and 10, there was a significantly higher exhale dispersion distance. And this was a distance, median distance in millimeters. So this led to concerns that probably, even if we use high-flow nasal cannula oxygen, we should probably limit the flow that we're using. So early in the pandemic, due to the hypothetic risk of transmission to healthcare workers at the beginning, experts recommended either restricting the use of high-flow nasal cannula oxygen, or if at all it was used, limiting the flow rate to less than 30 in critically ill patients. Now, this recommendation led to intensivists either not using it or adopting an early intubation strategy because they were limited by the flow. And early intubation was also practiced for other concerns related to the pathology of the disease. So the risk of bioaerosol dispersion associated with high-flow nasal cannula oxygen has since then been questioned. And this is another very elegant study that compares high-flow nasal cannula oxygen with oxygen mask and looks at environmental bacterial contamination. Now, this was not done in COVID-19 patients, but this was done in patients with bacterial pneumonias. And this was a randomized crossover trial. It was a non-inferiority trial done in a small number of patients. And they looked at the environmental contamination using bacterial plates and also air sampling, and very interesting findings. So they looked at the gram-negative bacteria and the total bacteria count at day 1, day 2, and day 5. And if you notice that there was no difference when high flow nasal cannula was used compared to conventional oxygen therapy in terms of the contamination with the gram-negative bacteria at various decisions or even the air pollution. So high flow nasal cannula, and Dr. Rochberg has already alluded to this, and this was a systematic review that was done for the WHO, and Professor Rochberg was a part of this systematic review where they looked at the effectiveness of the aerosolization, the dispersion, and the infection transmission. And this was a small number of studies, only 7 studies. 3 were in mannequins, 3 were done in COVID patients, and 1 was this study in bacterial pneumonia. And what they found was definitely there was a benefit with use of high flow nasal cannula oxygen to reduce the need for invasive mechanical ventilation in these patients. But there was very low certainty, the uncertain findings with regard to droplet dispersion and aerosol generation. So nothing to recommend that there would be these concerns if you used, different flows and whether we should or should not be using it. So no real concerns shown. Of course, these were small studies, mannequin studies, but this meta-analysis did not show any difference. Now, there's uncertainty about whether this is an aerosol generating, whether it generates aerosol and at what distance and how, but we do wear our personal protective equipment. And over time, we've begun to realize that perhaps if there is a benefit to patients with COVID-19 and we could avoid intubations, the known benefits in non-COVID patients, why don't we use it? And we know that appropriate PPE should protect us. So more and more confidence has come in using these non-invasive therapies that were presumed to be aerosol generating. Now, this is a very interesting study that I found in the Annals of Intensive Care. And this is from a group of French intensivists. And what they did is they put surgical mask on top of the high flow nasal cannula oxygen. And they showed that it could improve the oxygenation in critically ill patients and these patients who present with hypoxemic respiratory failure. So very interesting study. They looked at just using high flow nasal cannula oxygen and using HFNO with a surgical mask, and they compared different aspects, the PaO2, the SaO2, SpO2, the P to F ratio, and they also looked at the partial pressure of carbon dioxide because they would be concerned that there would be an increase in these levels. And very interesting, whatever concerns were expressed were not really realized. And their study shows that a surgical mask, when it's placed over the patient's face, who's already treated with a high flow nasal cannula device, would actually offer an advantage in terms of oxygenation in COVID patients. And this oxygenation improvement is also associated neither with a clinically significant change in the partial pressure of carbon dioxide, and nor were there any subjective patient complaints. And this was a review that was published in Critical Care very recently, and they've looked at practical strategies to reduce the nosocomial transmission to healthcare professionals providing respiratory care with COVID-19. And they've looked at the various strategies which put the healthcare worker at risk. And if you look at high flow nasal cannula oxygen, they've said the recommendation they've made is that you should have a proper fitting nasal cannula, and you should try to place a surgical or a procedure mask over the high flow nasal cannula to prevent further transmission or risk to the healthcare workers. Now, what evidence do we have for the use of high flow nasal cannula in COVID-19 patients in the intensive care unit? Now, this is a very elegant study using high flow nasal therapy to avoid invasive mechanical ventilation, and this was done in COVID pneumonia. This was a study, it was a retrospective study done quite early in the pandemic, published in Annals of Intensive Care and done by a French group. And here they compared standard oxygen therapy versus high flow nasal cannula therapy. And this was a retrospective study, and their primary endpoint was to look at invasive mechanical ventilation. And as you can see, there was a difference in the primary outcome between the use of high flow nasal cannula oxygen and standard oxygen therapy when looking at invasive mechanical ventilation. But this was a small study and a retrospective study, and it showed that high flow nasal cannula oxygen in COVID-19 patients with acute respiratory failure was associated with a lower risk for invasive mechanical ventilation. Another study that was performed by Alexandra Demoule et al., and this was published as a letter in the Blue Journal, high flow nasal cannula oxygen in critically ill patients. And here This was again a retrospective study, and they looked at 379 patients in the intensive care unit, and they compared those who received high flow nasal cannula versus those who did not receive high flow nasal cannula. And this study, it was a propensity score matched analysis were done, and this on the x-axis, as you can see, these were the days since ICU admission, and this was the proportion of the events leading to invasive mechanical ventilation, which, as you can see, were much higher in the patient in which high flow nasal cannula oxygen was not used. Now, this was another study from Professor Artigra, and using high flow nasal cannula in patients with COVID-19. And this was a prospectively done study, and they looked at high flow nasal cannula and early intubation and compared these two. And these were patients who presented to the intensive care unit who were on oxygen therapy, not ventilated, and they looked at intubation within the first 24 hours. This again was a propensity match study, and finally they were able to get matching in 61 patients in both the arms. And their primary outcome was ventilator-free days and the length of ICU stay. And there was a significantly more number of ventilator-free days and lesser stay in ICU in the patients who were in the high flow nasal cannula oxygen group. So they concluded that the use of high flow nasal cannula upon ICU admission in adult patients with COVID-19 may lead to an increase in ventilator-free days and a reduction in ICU length of stay when compared to early initiation of mechanical ventilation. Now, these were small studies, retrospective study, one prospective study. Now, do we have any data on what are the predictors of failure when you use high flow nasal cannula oxygen therapy with acute respiratory failure? Because this is very important information. And this was, again, an observational study, but a multicentric study done in Spanish, 36 Spanish and Andorran intensive care units. And they screened over 1,000 patients. 259 patients were finally included, and 140 of them were not included, and 119 patients were intubated. And these were patients who received high flow nasal cannula oxygen. And when they did a regression analysis to look at what were the predictors of failure in these patients who received high flow nasal cannula oxygen, it was the non-respiratory SOFA score and also the ROX index, which is the ratio of the P to F ratio divided by the respiratory rate, and they had a cutoff value of 3.5. So these seem to be the predictors of failure when high flow nasal cannula oxygen was used in COVID-19 patients. So small studies, retrospective studies, prospective studies with propensity matching done, but no prospective randomized controlled trials. And this kind of limited data leaves us, really asking as to what is the role of high flow nasal cannula oxygen. And very recently, I'm sure you've all seen this paper that's published in JAMA. And this is from Professor Antonelli and his group. And this has compared the effect of helmet non-invasive ventilation with high flow nasal cannula oxygen and looked at the respiratory-free day support in the intensive care unit. And this was in moderate to severe hypoxemic respiratory failure. And their primary outcome was days free of respiratory support, and a very nice elaborate protocol that they used. And when they compared high flow nasal cannula oxygen with helmet non-invasive ventilation, and when you look at the primary endpoint, respiratory support free days, there was really no difference between the two interventions. And the authors concluded that in critically ill patients with moderate to severe hypoxemic respiratory failure due to COVID-19, the helmet non-invasive ventilation compared to high flow nasal cannula oxygen resulted in no significant difference in the number of days of respiratory support within 28 days for these patients. Of course, the helmet may not be available across the globe, and that gives you some confidence that there is a good role for using high flow nasal cannula oxygen in these patients with COVID-19. So looking at the kind of studies that are available, very small studies, no randomized controlled trials, small studies, retrospective, prospective studies, but with propensity matching, we thought, why don't we do a Delphi on the use of high flow nasal cannula oxygen and try to establish what the exact role of high flow nasal cannula oxygen should be in patients with COVID-19. And we did this expert consensus statement using this Delphi process, and Professor Inav and Professor Jaber are part of this Delphi process. So I'm very proud to have led this expert consensus statement, this Delphi process that was published in Critical Care in March, along with Dr. Prashant Nasa and a steering committee, and 39 international experts, and very good geographical distribution of these experts, 20 countries, 6 continents. Just in brief, we had multiple choice questions, Likert scale questions, and we used Likert statements. More than 70% was considered as consensus, and for multiple choice questions, more than 80%. And we also assessed stability between the last 2 rounds. And based on this, we were able to achieve over 73% consensus in the management of acute respiratory failure. And based on our statements, we were able to produce 20 clinical practice statements. And I'll just talk about the statements on high-flow nasal cannula therapy. What was the consensus among the experts? And they accepted that high-flow nasal therapy should be considered as an alternative strategy for oxygen support. And in brackets is the percentage of consensus. High-flow nasal cannula therapy should be used in patients who are unable to maintain saturation more than 90, using oxygen delivery through a venturi mask, and also may be used in patients with increasing oxygen requirements. And you may need to, this therapy may avoid the need for tracheal intubation and invasive mechanical ventilation. So in conclusion, I'd like to say that high-flow nasal therapy should be considered as an alternate strategy for oxygen support in COVID-19 patients. And these concerns about transmission of infection has not really been established, and this should not limit the use nor the flow that you're using for high-flow nasal cannula oxygen. And we have preliminary data that shows that high-flow nasal cannula oxygen in these patients reduces the need for invasive mechanical ventilation, can lead to increase in ventilator-free days, and a reduction in the ICU length of stay, with no apparent effect on mortality. Of course, we need future studies to confirm these findings because the data is very limited. Strategies to reduce the infection for the healthcare workers should include the appropriate use of personal protective equipment, a properly fitted nasal cannula, and also wearing a surgical mask over the nasal cannula. Thank you very much for your attention.
Thank you very much, Professor Miatra, for a fascinating talk, a very important one at this time. We are particularly grateful for your having found the time to do this talk, given the difficult circumstances in your country. It's very much appreciated. And we will have questions for you at the end, so please wait. And Jean-Pierre, would you like to continue with introducing the next speaker?
Yeah, thank you, Sharon. So now I'm very pleased to introduce Samir Jaber, a French guy working at Montpellier in south of France, a very nice place. He's working in the department of anesthesiology and intensive care, and he has a lot of publication on ventilation about airway management and also non-invasive support. Thank you, Samir. You have 15 minutes. Et très heureux de te voir.
Thank you, everybody. Thank you, Jean-Pierre. Thank you, Sharon. I'm very happy to be with you. First of all, I want to thank Sheila, as said by Sharon, in this very difficult situation in India of all what happened. And I want to say to her, we are all with all the people in India in this very bad situation. I will try to focus mainly my talk on the perioperative and postoperative. My conflict interest, I'm a consultant with honorarium with Fischer-Paykel company, and I have no difficulty to say what I want to say with Fischer-Paykel because they never influence my different talk since more than 10 years. This is my objective during the next 15 minutes. The question is, which ventilatory support could be used after surgery? Now, actually, we have the possibility to use, as said previously, non-invasive ventilation using ICU or home or dedicated NIV ventilator. You can use NIV or CPAP home ventilator. And now, more recently, as presented first by Bram in the first talk, we can use high-flow oxygen therapy. Sorry, because during my talk, sometimes you will see some slides with high-flow oxygen therapy and other with OptiFlow, which is the code name of Fischer-Paykel, but is exactly the same for discussion. Just 5 minutes to recall some physiological point of view for the more young people. That's what are the main ventilatory support, especially after surgery or after extubation, to prevent reintubation or to treat. First of all, this is the airway pressure in yellow. You have in white the flow. This is actually you're on my spontaneous breathing ventilation. This is my breathing pattern. As you know, you are a sinusoidal flow with 0 centimeter plus minus 1 centimeter of water in the mouth. So when you applied a positive and expiratory pressure, as you see, for example, 8 centimeters of water, which called continuous positive airway pressure when it's used alone, called CPAP, and it's called PEEP when it's used with another positive mode. You have also a sinusoidal flow, and you just have the difference that you not reach 0, but you stay at 8 centimeters of water at end of expiratory pressure. So what is non-invasive classical ventilation is when you applied another positive pressure, which is a dynamic one, which is called almost often driving positive pressure. You know, here we insufflated 7 centimeters of water, often called pressure support ventilation. Then you have 7 plus 8, it's 15 centimeters of water, positive and expiratory pressure in all in the alveoli at the end of inspiration. So it's often called non-invasive ventilation by PAP or PSV plus PEEP, and the difference is that is active, non-passive like CPAP, because you need to deliver a pressure. It's deliver a decelerating flow because it's more physiological, and as you know, at the start of inspiratory, you have the maximum of flow that what we use this mode in an IV. This and where we can place high flow. This is my personal point of view. And high flow is between standard oxygen and CPAP. Not exactly a CPAP or PEEP one, because in reality you stand down at 0 at end, but expiration. But it's like a CPAP, a light CPAP, because you can deliver 2 to 4 centimeters of water at end expiration in the majority of the case, but not more. So what can imagine the approach? As said by Bram first talk, you have a curative one and a prophylactic or preventive one. Curative application of ventilator support is when acute respiratory failure is present, and the objective is in this situation to avoid intubation. In contrary to prophylactic or preventive, is to try to avoid the occurrence of acute respiratory failure in patients without acute respiratory failure, mainly in present at high risk. That's why when you look the different, for example, meta-analysis, you will see that we classified the patient at high risk or low to moderate risk. Obviously, you have a gray zone because it's not very strict. And for each situation, each indication you can use a low pressure, which is optiflow, because you have very low positive and expiratory pressure. You can use a real CPAP, which can reach more than 10 or 50 centimeters of water. And you can use a non-invasive ventilation, mainly when you have an hypercapnia associated to hypoxemia. Just a small publicity for the journal is you can read the last number of Intensive Care Medicine Journal in December, when you have all what every physician should know on acute respiratory failure, on mechanical ventilation, and you have several papers on high flow, especially as you see this by Bram Rochewell, who managed this very nice clinical practice guidelines, and other by Jean-Damien Ricard, and all the specialists, the experts in the world participated to this. You have to read these nice guidelines produced by the European Society of Intensive Care and Anesthesia, leading by Mark Leon and Sharon, as you see, and you can find some recommendation according to the evidence. As you see, you have low quality evidence to suggest the use of high flow oxygen for hypoxemic after cardiac surgery, but you have you see here the recommendation also are weak for other situations, but we will discuss this situation. This is the same slide showing first by Bram in the first talk, that you can have three figures in the original paper. You will see that in high-risk population, you don't have less escalation of respiratory support. However, in the average risk population, you have some benefit in favor of high-flow oxygen therapy. So just the prerequisite to use high flow, you can, for me, it's more easy to always separate the free function of the ventilation system, that the airway system, the gas exchange, that is the lung function, gas exchange, and the muscle pump, that is mainly the muscles, the diaphragm. So where are the action of the high flow oxygen? Mainly in using high FiO2 in gas exchange. You have the effect of the CPAP PEEP-like. Even it's a very low, less than 5 centimeters, between 2 to 4, but it's sometimes efficient. And this could be also affect the diaphragm mobility. And in my point of view also, you have an effect never reported, but now we are going in Montpellier study to evaluate the effect of upper airways, because we observe it in our practice, mainly in after surgery, in obese or in patient in post-anesthesia care, like CPAP, especially in patient with in obese patient with obstructive sleep apnea, you can have the same effect that the CPAP, and maybe you can limit it, the decrease of the upper airway diameter in this situation. Maybe it also participated to the effect that you observe. Obviously, you have, for me, it's the main action is the conditioning of the gas, mainly the humidification and the heat, which allow the better mucociliary clearance. And in my point of view, this is probably the main action that we observe, why observe the positive effect in this situation. This is my personal point of view. Obviously, we can discuss this one. The second objective one is the dead space washout, which could be very beneficial in some patients, especially in some hypercapnic patients or obstructive patients. Then you have the addition of all of this physiological effect. You could improve the comfort of the patient, and the results are the decrease of inspiratory effort, mainly by decreasing the work of breathing. This was clearly and nicely reported in this paper that I presented first, leading by Jean-Damien and Gonzalo Hernandez, which explained the different mechanisms that I presented to you in this slide. This is the same one. You can see you have probably 5 major effects, which could explain, but probably the humidification could explain why in high flow oxygen, very high, you have the positive effect. This is to understand why we could use this in the post-operative period. This slide summarizes the main modification of respiratory function, as you see, which leading a restrictive syndrome, all the association of this, and a diaphragm dysfunction with atelectasis. This is a vicious circle, as you see, which leading to hypoxia with respiratory failure and pneumonia, which could worsen by the fluid overload during surgery and during the anesthesia management. The consequences of a post-operative pulmonary complication, as you see, you have an increase of mortality. Patient with acute respiratory failure after surgery reported here 60% of mortality in comparison to 0.3% in patient without non-acute respiratory failure. That our challenge is to avoid this complication after surgery. This is a slide to summarize the different strategy. From the left to the right, you have standard oxygenation. You see here very low oxygen therapy, the high mass concentration, the high flow oxygen, and the different strategy of high flow, CPAP, BiPAP, and IV, and at the end, unfortunately, intubation for invasive ventilation. So the paper, this leading by Bram, as you can see, Bram presented us the 5 and the 4 main recommendation, and we'll focus on this surgery part, and mainly you see the abdominal, cardiac, and thoracic. This is with my friend Emmanuel Futier. We published recently the pump ventilation. It's the approach that we should avoid the complication after surgery by using positive pressure from the beginning, the preoperative, intraoperative, and postoperative, and we reported the effect of non-invasive ventilation by the NIVA study. We showed that the NIV could decrease the rate of reintubation in patients who developed acute respiratory failure after abdominal surgery. You can see here we decreased by 30% the rate of reintubation. So what about the prevention of hypoxemia after surgery? We performed with our group the OPERA study leading by Emmanuel Futier and our colleagues, is to evaluate high flow oxygen to prevent hypoxemia in abdominal surgery. You see here the inclusion criteria. We anticipate duration of surgery at least 2 hours or more. We not included the obese patient and the emergency surgery in this situation. And the primary outcome was the hypoxemia 1 hour after extubation and at the end of allocated treatment. The secondary outcomes are the classical ones. However, the results are totally non-significant between the two groups. That means between high flow oxygen therapy and standard oxygen therapy in terms of occurrence of postoperative hypoxemia. And the same is true for the postoperative complication. So it's really, we were disappointed. And the same is true, as you see, for all the different secondary outcomes. So it was a negative study. Why it not worse? One hypothesis is that the patient who have not received the no positive pressure during surgery cannot be treated by high flow oxygen, because to avoid or to reopen atelectasis, we need high pressure, more than 5 to 6 centimeters. That means that's why we use non-invasive ventilation to open the alveoli. However, for those who received the standard positive pressure during surgery, that's called the improved strategy, have a better outcome. So what about thoracic surgery? We have this nice study from our friend François Stéphan in Paris, who performed a high flow oxygen therapy versus non-invasive after cardiothoracic surgery. And this study was a positive one because it's a non-inferiority study, because you see this Kaplan-Meier curve is absolutely similar, with similar reintubation rates using either non-invasive ventilation or high flow oxygen therapy. And in the group of obese patients, the same is true in this strategy. So this is my last slide. My take-home message is always, front of postoperative acute respiratory failure, please eliminate before everything a surgical complication. And if you have a clinical and gas exchange improvement, you can continue to apply high flow oxygen therapy. However, if you have no clinical and gas exchange improvement, please stop and probably intubate the patient or use another strategy such non-invasive ventilation. Finally, my take-home message are the following 3 points. As I said, postoperative acute respiratory failure, the main message, please always eliminate surgical complication. That means you need to have a CT scan to eliminate a complication and to consider reoperation. The second, high flow in selected postoperative patient could be proposed. We have today strong evidence of safety, then at first-line therapy to prevent or to treat hypoxemia, or as an alternative to CPAP or BiPAP, as reported in cardiothoracic surgery, mainly by the study of François Stéphan. Finally, please, like other strategy of non-invasive ventilation, high flow should not delay the time of reintubation. Thank you for your attention.
Thank you, Samir, for this very amazing presentation with so much figures. So perhaps, Sharon, you can start with the first question.
Yes, so we've been receiving questions from the audience, and we too have questions. It depends on the amount of time that we will have. I'd like to start with Dr. Miatra. We received the same question twice from two different people regarding the effect of face mask, surgical mask on top of the high flow nasal cannula. Do you have any thoughts on why it increases FiO2 or why it increases perhaps PO2 and any infectious issues?
Right. Actually, I found that very interesting because I thought the idea of putting a mask over the hypronasal cannula was basically what to avoid transmission of whatever aerosol was generated to the staff. But an interesting finding, or maybe it was just an association, was there's also increase in the saturation and also no increase, significant increase in the PaCO2. So I mean, the authors also haven't given a definitive explanation for this, but definitely from an infection standpoint, I would say that we cannot swear and say that there is no aerosol generation. Of course, we have our PPE as a frontline, final kind of thing to protect us. Nevertheless, if putting a mask over the hypronasal cannula oxygen doesn't produce any adverse events, why not do that if there's an additional protection against aerosol generation?
Thank you. Unless, Jean-Pierre, you want to ask something, I also have a question to Bram about peri-intubation.
Yes, then I will ask a question to Samir about this
please
study.
do. Please
okay.
do.
First, Samir, for conclusion, you said that you can use high flow as an alternative to NIV. Does that mean that your first treatment will be NIV for this patient, and how long you use this oxygen support in your patient, or through your study you report it?
Thank you, Jean-Pierre, for this question. In our practice, we use both. That means you use mainly after abdominal surgery in intensive care or in post-anesthesia care, non-invasive ventilation to prevent atelectasis or to treat, because non-invasive ventilation deliver high airway pressure. You know, that means you use at least 5 to 6 centimeters of PEEP, and we use at least 4 to 6 centimeters of pressure support ventilation. This is absolutely necessary to reopen the lung in some case of atelectasis, because we reported that high flow oxygen could not reopen the alveoli, because to reopen closed alveoli, we need more than 2 or 3 centimeters for the whole lung. But we use high flow oxygen therapy for all the patients between the non-invasive trial. We use preventive non-invasive trial in all our abdominal surgery, because in ICU we receive the high-risk abdominal surgery. The other goes to not in ICU, they go to the wards. So our approach is to probably use both, not contradictory. I think we should not consider competition between non-invasive and high flow. It's absolutely synergic. We use in our practice preventive NIV trial at 5 to 6 hours per day by trials of 30 minutes, like in physiotherapy, and when the patient tolerates it, because sometimes the patient is not in acute respiratory failure or don't have dyspnea, we try to explain to the patient that it's like physiotherapy, kinesiotherapy, and it's better accepted.
You applied a short session many times a day.
Yes, it's better accepted than long session. In fact, in our practice is around 25 minutes, started from 10 minutes to 1 hour, depending the tolerance of the patient and the severity. That's why I said we can always say preventive, curative, but in the real life, it's sometimes gray zone. We have a lot of liver transplantation patients. We can start with them. It's very apneic patient, no problem. And at the start of the on-call now, for example, at the end of the night, you have a patient with respiratory distress. Then the same patient could be prophylactic, gray zone, and unfortunately, curative situation.
Okay, thank you, Samir. Sharon?
Yes, we have a couple of very interesting practical questions from the audience, so we'll skip mine and we'll go to the audience's practical questions. One that I found particularly interesting is how you handle gas swallowing and stomach dilation. Is there any level or a specific level of PEEP or pressure that you would put an NG tube in? And the second one, and if you could answer both, this is to all the speakers, how do I know whether to increase the FiO2 or the flow, particularly in COVID-19 patients? If anybody has any idea how to respond to these, it would be great. So let's start with Samir. Do you want to perhaps respond to the NG question?
I want to be some courtesy for Sheila. I prefer Sheila start for the last question about.
Okay, so ladies first. Okay, so I will address the second question. I will address the second question, if I may. So regarding titrating the flow and the FiO2, a lot of times people think this moves in parallel, but actually you have to set them independently. So I would set the FiO2 based on my target saturation that I want to achieve. And of course, I'm not aiming for 100% saturation. I'm okay if they are sitting above 90. So I would titrate the FiO2 to the level of saturation that I aim to achieve. And regarding the flow, I would look at the patient's work of breathing, the respiratory distress. So initially, of course, you have to start with a much you start with a high FiO2 and you come down to your targets, come down with the FiO2. Regarding the flow, you have to start with a lower flow because this is not well tolerated. Though you're giving heated humidified oxygen, it's not well tolerated by the patient. And then you gradually increase the flow to match the patient's comfort level. So I look at how, what is the respiratory distress, what is the work of breathing, and I increase the flow just enough to make the patient comfortable. Now, in the COVID era, we are concerned about giving high flows, of course. So you don't have to keep everyone at 60 flows. I come down on the flow. If I see the patient is comfortable at 40 and 30, I come down to lower flows. And also, presently in India, we're facing a shortage of oxygen. So we're trying to come down on the flows as far as possible, but of course, giving the patient what he needs.
So oxygen conservation is not a strength of the high flow nasal cannula.
Yes, I can report our practice and my personal recommendation today. We initially start by the application of the Florali protocol. This is absolutely the recommendation initially. The recommendation protocol made by Jean-Pierre in the first landmark study. But now, and as said by Sheila, the tolerance is very poor in postoperative patients. So my position is now to always put the FiO2 setting to 100%. This is our practice, and to always just decrease the flow, because the flow sometimes more than 13 or 14 in our patient is not well tolerated. So, and moreover, I don't believe personally about the CPAP effect. I don't believe it. I believe that it's very small positive pressure. We performed several studies and we showed that the mouth open, you never have more than 2 or maximum 3 centimeters of water in all the situations. So in my point of view, the effect of PEEP is very, very low. In my point of view, this is some data showed, and that's why we prefer to use high FiO2 and to benefit of the humidification and heat oxygen therapy. And we decrease more and more and it's better psychologically for the nurse and the doctor to have a lower flow with FiO2. This is our position. Maybe it's totally open. I know that Bram, you have another position, but it's very interesting that they think to discuss this point of between pragmatic bedside practice and some literature point of view.
I think it does depend. It is great perspective, and I certainly agree. And I think that there is a little bit difference between patient populations as well. You know, perhaps in the post-operative setting, they don't tolerate the high flows as well. But my experience sometimes in those that come in quite hypoxic and air hungry is that being able to titrate up those flows is what actually helps address dyspnea and better matching those inspiratory demands, especially in patients that are so dyspneic and breathing in a rate in the 40s or 50s. I get more, sometimes I put it on just for flow. They might not be actually hypoxic or that high degree of hypoxia, but by titrating up the flows, I'm able to deal with the dyspnea and buy me some time to evaluate to see whether they would need to proceed to intubation or not. So I do think that there's a little bit of subtype of patients and titratability.
Yes, but we have probably both. You have the FiO2 effect, and that more you increase the FiO2, more you increase the real oxygen delivery in the trachea, as you know, because in the very acute severe patient with a high oxygen demand, with we're having the high demand, you need to have a high inspiratory flow, and then you never reach more than 80% in the real life of FiO2 in the alveoli. That's probably why in this very sick patient, the very sick hypoxemic patient, it's better tolerated high flow than the other one. You're right about the selection of the population.
Yes.
Thank you. I don't know if we have enough time for more questions, or
I can ask a question for Sheila. Sheila, what is the main practice now in India? Because we are it's hard for us to see what we see the television every night, every evening. We see what happened in India, and we are very sorry for what happened. And what is the main practice in the ICU or in the post-intensive care? What is the main ventilatory support used today?
So first, I just like to say, don't go by just what you see in the media. Things are pretty much under control now. But across the country, we've become very conscious about oxygen conservation. And we're not, we're taking all kinds of measures to limit the use of oxygen. So it's not that we're saying don't use high flow nasal cannula oxygen, but we're trying to say, you know, use it only if you absolutely need to use it. And if at all you can come down on the flows at the earliest. You know, don't just keep everyone on 60 flow. If you can manage with 30 flow, 40 flow, you know, we're checking for leaks. We're not trying to target 100 saturation. So various measures are being taken, not only in areas where there's shortage, but even where there isn't shortage, acknowledging the fact that we have a huge number of patients who are coming into the ICUs. It's almost like a tsunami, you know, large numbers. So we're very conscious about this and trying to limit the oxygen that we're using.
Thank you.
We have
so we
perhaps a last question, Sharon, if you agree, about
sure.
the use of high flow, prolonged high flow therapy, and the problematic of oxygen toxicity. I think there is no data about that, but perhaps you can answer to this question. High flow, prolonged high flow, and oxygen toxicity. Bram, in meta-analysis and this other study you made, did you find something about that?
Yeah, unfortunately, at least in our reviews, no. Although, you know, we focused, especially for the guidelines, more on patient-important outcomes. And we did look at mortality at 30 days for a lot of these interventions, especially in hypoxemic respiratory failure. We looked at ICU length of stay. We looked at duration of respiratory support. And certainly if you expected, with prolonging high FiO2 therapies with high flow and oxygen toxicity, increased free radical production and harm via these pathways, you might expect impact on some of these patient-important outcomes like mortality at 30 days, hospital mortality, duration of ICU, and we did not see any harm in terms of looking at these. So not to say that it's not a risk. I certainly worry with setting such high FiO2s over a prolonged period of time, but it doesn't, at least from a meta-analysis and evidence summary perspective, translate into those patient-important outcomes, at least based on the data we have.
Thank you.
I don't know if my colleagues want to add anything else.
Jean-Pierre, maybe we will have more data in the next 2 years by the MEGAROX study. The MEGAROX study is a study leading by the ANZIC group, which will include 40,000 patients with liberal versus restrictive oxygen, but included all patients. That means acute respiratory failure and patient without, and we will see prolonged effect of this. This is crazy study. We have to see the results about it.
Yeah, and
yes,
in
but,
the interim next month, you should all expect to see the results of the PRISM trial, which is coming out. 4,000 patients randomized to CPAP. Very interesting results. We should all look forward to that.
What are the results?
Can't tell you.
You can
read the discussion. So thanks, Jean-Pierre. Could you perhaps say thanks on our behalf to everybody? For me, it was a great pleasure to be with you guys here and with the great audience. And please.
Thank you, everybody, for this all your presentation, and I hope that that will help everybody to use high flow or other oxygen support. And yeah.
So thank you for being with us this afternoon. Great talks, everybody, and great audience. Thank you.
Thank you. Goodbye.
Bye-bye.